must constantly look at things in a different way.
The Healthcare Education Transformation Podcast was created by two physical therapists out of the desire to learn more about the different educational roles in physical therapy and healthcare, and how healthcare education works by talking with educational leaders and people with different perspectives within physical therapy and across interdisciplinary lines on how education can be improved to disrupt the status quo of healthcare education. This is our journey, and thanks for listening. Hey everybody, this is Brandon. And from all of us here at HET, we again just wanted to thank all of our listeners and our guests for all their incredible support throughout our journey as we really strive to continue to provide really valuable and important content to all of our listeners to really help advance the educational realm and really help push things forward. For this episode, we chatted with Dr. Carole Lewis and Dr. Ken Miller. And for this episode, unfortunately, the audio quality is not as clear as our previous episodes. We apologize for the inconvenience. Now, without further ado, we now present our interview with Ken Miller and Carole Lewis. Hello, everyone, and welcome to another episode of the Healthcare Education Transformation Podcast. My name is Brandon Hohen, and of course, as always, I am joined by my other co-host, F. Scott Thiel. And today we welcome two very special guests for a good discussion on advice for the therapist in the hospital and the home health setting. Today we welcome Drs. Carole Lewis and Dr. Ken Miller. Now, for those who don't know, Carole Lewis is the 2016 McMillan lecturer, and her lecture, Our Future Selves, Unprecedented Opportunities. And she is the second McMillan lecturer that we have had on the podcast, followed, of course, by Gail Jensen, who was our first one. Greatly appreciate your time and work for the profession. And, Carole, I'd like to start off with you, and, talking with your 2016 McMillan lecture, Our Future Selves, Unprecedented Opportunities. And, when I heard your lecture, I really appreciate the blend of stories, humor, and call to action and I think you brought up a lot of good points throughout your talk. And I was really impressed that you got Mary McMillan herself to do 2 cameos throughout your lecture.
Thank you.
Yeah, I don't know how you pulled that one off. And, and I like how your talk had 4 main take-home messages, including, dedicate a course to geriatrics, commit to lifelong learning, refocus on the clinician, and really focusing on this idea that aging equals unprecedented opportunities. Now, my first question to you is, where do you feel that we as a profession now overall stand in regards to your recommendations that you made in your lecture?
Well, let me just say, I think more people are focusing on dedicating a course to geriatrics, which I really think is the key. I mean, what I said pretty clearly was, the students are coming out and they're not really prepared for working with older persons. And so and in most situations, that's the majority of what they're seeing is older persons. So we have to have a course. I mean, people come out, they think they're prepared, but they really haven't had a course. So that's the first thing that needs to be done. And I hear that people are saying that's happening. I think we really have to get to CAPTE and the licensing body and say, look, you've got to do this. And I know that practitioners want it, especially people in skilled nursing and home care, who are pretty much saying, you're sending us clinicians that aren't prepared. So I think that is by far the first thing that we have to do. And I do see that it has changed. So I think that's wonderful. I also see more and more clinicians that are seeing the older person as a real opportunity, working with older people. So I think that's great. There are so many things that we can do with the older population. I was just so excited. I taught a class last weekend in Charleston, and people were coming up telling me how they're building these very cool niche practices, combining home care, going into exercise facilities, and setting up small little niche clinics to see just screens for older people. So I think people are recognizing it and seeing, particularly the baby boomers who have the money, who have the knowledge, who can really appreciate what we do. So I'm very excited about that. To me, those were really the most important things to get across. The problem is APTA has to recognize the clinician as the focus, and the only way that's going to happen is for more of us to get in there into APTA and demand, that we stop seeing that, research agendas are the only thing that's important, but that we're important. that APTA get up in front of Medicare and really make a stand for the clinician. So that is hard, a little harder to get working through an association. But I think the first two that I talked about, we really made some great strides.
Yeah, those are some great points, Carole. And I think curriculum-wise across the country, you're starting to see some aging adult or older adult courses popping up in every PT program. So I'm glad to see that as well. I'd like to know, what are the biggest issues that acute care, skilled nursing facility, ICU, and home health physical therapists are facing nationally? And what exactly should we be doing to address these issues?
Well, I think the biggest issue is we need to teach society what we do. And I think that starts with CMS. I mean, the fact that I hear that there's cases coming up that are accusing a lot of these places of not providing appropriate care. I think the government's going after the deep pocket, and they're just trying to get money back from us. I mean, oh my gosh, the literature clearly says that some of the surgeries that we do, that we pay for in this country have absolutely no evidence. But physical therapy has so much evidence, yet we're being held to the wall by the Justice Department, who's saying, well, you didn't dot your I and cross your T, so we're not going to pay for millions of dollars worth of your claims. I mean, that makes me crazy. I mean, it's a big problem in skilled nursing. It's starting to come to Part B, home care, and it's really upsetting me. We have got to educate them that we're cost savers, and I said this in my lecture, in the healthcare system. If we get edged out, this healthcare system that we already have that costs too much money is only going to cost more. I mean, it's clear. There's studies that say if you go to a physical therapist first for back pain, you're going to cut your costs dramatically. You have much less chance of surgery. We need to be the front-end providers in every setting. Skilled nursing, home care, and use our knowledge. I mean, okay, so that's the piece where we have to educate the consumer. The other piece is, there's some therapists out there that aren't practicing at the top of their game. And so if we're telling them we can do all this, I know I can say it for myself. I think that sounds a little too pompous, but I think I can. And for other therapists that I work with, that we know our stuff. But there are some therapists out there that just don't care. They take crummy courses, and they learn crummy stuff, and they bring that back to the clinic with their patients. And I don't think they're there being evil. I just don't think that they really believe it's important to keep at the top of knowledge. And you know what? If we are going to be front care providers, we have to be as good as we can possibly be. And so I think that's very, very important. So those are the things, I think, the real crucial issues. I mean, I have a lot of people that come up to me that aren't in geriatrics and say, well, the people who work in geriatrics, they're the worst. That just makes me so angry. But I do think that there are some people in all settings that just don't care. And they're giving us a bad reputation. So what I want to say is those people, take the time, to learn good information that will help you give the best care to your patient. I think that's important. And then share that with people who are paying our tab, like CMS, the insurers, and let them know that we really are cost effective.
Yeah, so in targeting more of the solution from the education perspective, the Best Practices in Physical Therapy Clinical Education Task Force came out with 7 recommendations on improving clinical education, and we're currently awaiting the results from the November Board of Directors meeting. What are your guys' thoughts on how these recommendations would affect acute care, home health rehabilitation specifically, and how do you both feel that clinical education needs to change?
I think that the recommendations are very, very future thinking. However, the first recommendation, which was highly debated at the ELC conference, related to a stepped licensing program, trying to have the states license therapists more along the medical model, where therapists will graduate, have to go through a residency, and then have a licensing process that's a stepped process. Really, the debate ended up being that would be a practice inhibitor, and that really the care that the training that therapists would get would ultimately be outside of APTA, outside of CAPT, and really move into the clinical setting, into the employer setting. And so a lot of clinicians felt at ELC that really is not the way that APTA should be headed. Now, I think most people are in agreement that we need to have higher learning in the residency fellowship model, but having a stepped licensure program really puts more caps on our profession rather than focusing on our autonomous practice. So I don't know, Carole, if you have anything to add to that.
You're talking about the one where they're saying, because I'm not sure everybody knows what you're talking about, but I think you're talking about the one where, because I'm not familiar with all of them, but this one I am, that, okay, you graduate and then you really don't have a full practicing license until you become like an intern, similar to medicine, and then a resident, and then a fellow in a specific area. For example, it really is not, it's going to be very difficult to be a generalist. Is that the one you're talking about?
Yes, so that's a very good recap. And a couple of the biggest challenges of our profession to try to move in that direction is, I agree that when current practices, we graduate, we have our clinical rotations, we graduate, we get our license, and then there is a lot of learning, once we're licensed, and that's where, mentorship comes in, and our current model of residencies comes in, and I think that model needs to be revamped. I think it needs to be reviewed and changed, and I agree that there needs to be post-graduation continuing education of the quality that this is going to sound solicitation, but like Great Seminars has live courses. There are other mechanisms of getting continuing education where you learn the cognitive and psychomotor domains of learning. You can't do everything online, and I think if we don't invest in our own education with cheap type CEUs, then we get what we pay for. But moving back to the question with the best practices in clinical education, they're looking at ways that we can promote best possible practice in clinical setting and moving that outside of the academic setting completely more into the employer world. I don't see that as the way to go. And I really think that we need to really look at how we're providing current clinical opportunities and try to revamp those and encourage those. But when we talk about making the license a step process and now limiting people and forcing them to go into specialties, I think that there's a problem with that. Many clinicians work as generalists for a number of years and really get a nice broad experience and nice broad practice. And then once they truly know the general practice, they then specialize if they choose to specialize. And there are many clinicians that choose never to specialize and work as a generalist, and they're just as successful and just as effective with their patients.
Yeah, and what worries me is that APTA starts like this. If someone comes up with this sort of very far off the radar screen idea, and we all think, oh my gosh, can't do this, and then all of a sudden it becomes the norm. And it worries me that might be what goes on here. I think we'd like to follow that medical model, and I think that's not us. We are not medicine. We're not physicians. We have our own way of practicing. And I think we're creative enough that we can come up with a better way. I get it that the body of knowledge is growing exponentially. And if you leave everybody out there as a generalist, and you don't really signify who is the specialist, you're going to have some issues. But I totally agree with you, Ken, that you don't want to make it so people can't practice as a generalist. I think for me, those years I had before I decided I wanted to be a geriatrics made me a better geriatrician. And I think practicing as solely as a geriatrician, and what happens if you get into that and you decide, oh gosh, I really don't like this, and now the way the model they're suggesting is, I don't know what you do. I guess you have to go back 2 years or whatever and practice in the pediatric setting, let's say. And we will lose that flexibility. And I don't think going through this residency fellowship, that's very rigid like this is the way to go. I like it for electives. I think it's okay for people to pursue their interests, but for it to be license dependent like you're talking about, that really scares me. And I can't imagine we can't get some brilliant people together, brainstorm and come up with a better way.
And you brought up earlier about CMS and reimbursement. I can't see us doing something like this without first having the mechanism in place for being paid. A lot of times what we've seen in our industry, APTA, we make all of these broad statements. We want to change this and change that. And to me personally, I feel like we're just talking in our own circle, and we're never approaching CMS and getting the reimbursement to change as we're trying to drive better practice. And if you look at practice today, there are so many things that you said and I agree with about evidence-based practice, that therapy actually can prevent illness, things that therapists can do to prevent frailty or reduce pre-frailty and help improve population health. And none of these things are covered by CMS, and really we're not talking to the right people. I think in order to drive some of these changes, and this specific issue on the residency I do not agree with, but in order to drive change, we have to be with CMS to make sure that the reimbursement model adapts as we try to adapt practice to better practice. And I think we've not done a good job with advocating for the financial mechanisms to be in alignment with what we're trying to accomplish as therapists.
No, I agree.
No, I think that's interesting, guys, and you brought up a lot of good points in there. And I guess, when I first read that recommendation, my biggest concern was, how is this going to change with cost-wise? How are we going to find a cost-effective way to do that? That was my biggest worry when I first heard that.
Yeah, no, I agree.
Now, guys, kind of to switch gears a little bit. Now, Carole, I'm going to ask this one specifically to you. For the newer clinician, or, who's been out maybe anywhere between 1 to 5 years, or any clinician for that matter, working in an acute care, skilled nursing, or hospital, what are some of the most important clinical pearls that you've learned based from clinical experience and based on what you've read from research that you feel that all therapists in those settings should be aware of and practicing on a regular basis?
I'm an evidence junkie. I spend at least an hour every day working with what's out in the literature. And you don't have to be crazy like me, but I think using evidence, and what I am with the newer clinicians is they are questions. Unfortunately, I think my generation was educated by the textbook, and the textbook, having written them, I have this new book that Ken was an author for, and when I wrote the prospectus, it's all electronic. There's no paper, and when you push a link, it takes you right to the video about the examination or the intervention. It's 2,000 pages with 400 videos in it. So it's pretty cool. But the other thing that I love is when you click on the reference, it takes you to the actual PubMed abstract so that you can see the strength of evidence. And so the reason I was so insistent on this is because, when I went to write the prospectus, I thought, okay, I'll write a chapter on posture. And I sat down at the computer and I started typing. More forward head, rounded shoulders, and I thought, how do I know this? So then I went to the literature and I realized some of the things that have been in my textbook since 1985 have no evidence behind them. So then I started writing a chapter with, all right, Gabralzik, Edenhoff said, and then I noted where you had those postural changes. And it was evidence-based. You see that they looked at 1,600 seniors. I don't type all that in there, but you can go to a reference that says this is evidence. I mean, therapists, unfortunately, are taught things in school that may not be evidence-based. And I do think students are becoming very astute to asking that. But it doesn't end when school is over. When let's say you're in acute care and you're going to be seeing people who have total hips or hip fractures, take the time to look up, just even Google on Google Scholar, which is my favorite, current treatments for hip replacements in rehabilitation or hip fracture. Another thing that everybody subscribes to is Amadeus, AMEDEO.com. It's free. It's a service that you go into, you click in rehabilitation, you click off the journals you want, and every week they will send you what articles are published in that area. So it's pretty cool that it keeps you on top of all the literature, AMEDEO.com. They don't spam you, and it's just a great free resource. But that's the kind of thing, stay on top of evidence. Otherwise, and I think what's really made our profession so great in the last 20 years is that we are using evidence, and we're getting results, and we're seeing it, things like, we're better than carpal tunnel surgery. Revisit, this newer study that came out with a therapist, and people don't need carpal tunnel. That knee OA patients don't necessarily have to get total knee replacements if they see a therapist for a great program. So there's a lot out there that show that we're effective, but only if we're using the evidence. So that would be my pearl. I think it's more motivational. The number one reason for compliance for patients is that the treatment made a difference. If it makes a difference, they're going to do the exercises. If you're giving them the wrong thing, they're going to come back and not do it. If it's making them better, of course they're going to do it. So we have to make sure we get the right thing to them. All right. That wasn't a pearl. A pearl in like 20 minutes, but that was a pearl.
No, well put, Carole. Well put. Now, Ken, you've been a repeat guest on the show. You're actually one of our first, so we do appreciate that. But I'd like to hear your point of view from the newer clinician working in home health, or a fresh DPT grad. What are some of the most important clinical pearls that you've learned based on your clinical experience and research, maybe that you didn't get in school, that you feel all home health PTs should be aware of and practice?
I would have to say that number one, especially if you're in the home health setting, but number one for all new grads is to get networked. If they're part of the APTA and have colleagues, if they join any of the sections, the Academy for Geriatric Physical Therapy or the home health section, I think getting networked with like clinicians that are involved in researching the evidence, in gathering the evidence, the more people that you're networked with, you can collaborate on what are best practices. And instead of looking at research from a singular view, you now have a broader view, and you also gain the experience of the other colleagues in your network. And I find that my role of being the chair of the practice committee really expanded my practice and helped me to see patients in a much different light than if I had done it solo on my own as a lone ranger. I think that clinicians that graduate that feel like home health is an isolated environment and I can't learn in that environment, I think that oftentimes is true when the clinicians don't have a support system in place. But I don't think that that's the rule. I think that can be more of the exception to the rule. And sometimes it has to be internally driven. Carole brought up, and we talked earlier about lifelong learning and making sure that we're always trying to grow and learn and teach ourselves and learn from others. It's up to us if we're in an environment, and this is in the hospital or any practice setting, if we're in a system where we feel isolated and we're not growing and we're not researching and we're not learning from each other, then we need to be the person to reach out to others either in that same practice setting or outside the practice setting to other clinicians to find out how we can adapt our practice to make sure that we always stay current. One other thing that I think is critical for all clinicians, and Carole talked about compliance, is really getting to know our patients. There's a lot of research that's entering into the physical therapy discipline from the world of psychology and from social work literature regarding biopsychosocial model of care for patients. I graduated back in the olden days, and I'm seasoned. And so when I went to school, we learned about the NAGI model. And since more recently, therapists are now graduating, having gone through learning about the ICF model, which is a biopsychosocial model. So I think clinicians that graduate and go into home health or any setting look at patients a little bit differently. And I think knowing about the patient's environmental factors, personal factors, what makes them tick, really helps to improve the therapeutic alliance and helps to get better engagement and activation of our patients. And I think then you see greater results because the patients are actually following through with the recommendations that we have. Clinicians that don't engage their patients will not see the same outcomes. And the literature and evidence is surely there that the more we engage and activate, the more they're likely to follow our recommendations, and we see the better outcomes with that.
Yeah, that's a great take, Ken. Carole, what advice would you give to a newer clinician working in acute care or a skilled nursing facility or a hospital to be most successful in avoiding burnout when they're starting out?
Okay. It's funny because I do give a talk on burnout pretty frequently. And it's funny, the people most likely to burn out are people that are 2 to 5 years into the practice. So the brand new graduate is not. They're the second highest. But once you've made it past 9 years, you're pretty much in for the run. So the most likely to get burnt out are 5 to 9 years, and then at the second group is the 0 to 2 years. So I think what people have to realize with burnout is we take on too much sometimes, and that's why I make a little nervous that I said, oh, you got to do the evidence. I'm not saying spend hours a day, but just take a little bit of time for that. But more importantly, take time for yourself and make sure there's a couple things going on. One, you really love what you do, and that's one thing that I find in the area of geriatrics, that when I ask my class, why do you do this? What do you love about it? And they love working with these patients. They love their history, they love their stories, they love their complexity, they love their appreciation. So you gotta love what you do. You gotta be somebody that gets a lot of joy out of this. And we're lucky in many respects that our professions are incredibly healthy. Number one, we get up and move around, which in the studies show that's better than working out, going out and running 2 to 3 times a week or regularly. If you get up and move around, you're healthier. So one of the things is what we do is healthy. The other thing is about our profession is we're helping other people. I can't tell you how many times I talk to my peers who, sell insurance or work on computers, and they kind of feel like they're not doing anything meaningful. So I think we have to keep hearing that and taking that in so that we feel good about what we do. The other thing is, and I know a lot of therapists don't know this, but we work in a negative work environment. And I know they think, oh yeah, no, it's not negative. Yes, negative. A positive work environment would be being the cruise director on the Love Boat. All right, we're working with people that one day were, walking around moving now because of a broken hip or a stroke. They can't move. That's pretty negative. But we are such a positive group that we make a negative work environment positive. However, that can burn you out. So we need to do things that replenish our energy, that give us something back. One of the things that we do is we deflect. People will say, oh, thank you for working with my mom. And what do? We go, oh, no, it was your mom. No, it was you. Take it in. Don't deflect those things. It's not a positive work environment. When you get the positive, don't deflect it. So those are things that we can do to keep ourselves strong. So appreciate also. I know a new graduate might not be ready for this, but have a goal 10 years down the road. I love, for example, I have a friend who's working in acute care now 40-something years. Loves every second of it. Loves telling me about, well, I got a silver watch 10 years and a gold watch at 20. They give you a rocking chair at 50, So she's really into it. Loves seeing patients like that. So she's found her gift and joys. But for some people, it might be teaching. For others, it might be community outreach. For some others, it might be, mentoring somebody in the clinical setting. Find what you really like. And it's going to be hard. You're sort of getting your feet on the ground. But pay attention to the things that when you get home, you feel light and airy. That was a great day. If you feel, oh my gosh, then figure out what it is in that day that's doing that to you so that you don't burn out. This is a great profession. And it hurts me when good people leave it to go to something else, not for a good reason, for burnout. Because burnout can happen in any field. And I know people that leave and go away to become a lawyer, let's say, are going to burn out in law too. You got to recognize what works for you. And this profession has so many opportunities. I mean, just look at the specialty areas, then look at all the settings we work in, and then look at all the ways we can deliver our knowledge base to the community, to our peers, to our patients. So there's just so much to do. And I think if you keep that in mind as you go through each day, I don't think you'll burn out.
No, Carole, I think those are some great points. With me being a relatively newer grad, about 2 years out, I can definitely relate to some of what you said in there as trying to finding your goal 100%. That's actually kind of the reason why we kind of started this podcast because, myself at least, I want to pursue more of the educational role in some form, but I don't know what avenue to go. I feel like I don't know a lot of the real world, about how it actually works. So this has kind of been like our quest to kind of learn about it, to kind of make a decision and help others that are kind of considered that too. So I think that was a very true point. And another thing that I kind of always thought about, and Ken kind of mentioned on this earlier, was about the reimbursement pressures and how it changes clinical patterns. And then, because I know a few friends of mine that are feeling like they have to see so many patients at this time, otherwise, they're not going to make the budget, and then therefore they feel like they can't spend the time to get to know people, and they don't get the outcomes, and they get frustrated. And I mean, that's definitely a contributing part to it too, I think.
No, it is, and that's a hard one. It just upsets me terribly, that whole thing, and we got to fix it. I mean, I still tell your story. Maybe I shouldn't say it on here, but Ken comes up to me and he says, well, let me tell you about what my life is like in the evening. He says, my wife and I are in bed, and I think, oh, Ken, stop right there. And then he says, no. He says, she's on her computer, and she's watching movies. He says, I'm on my computer doing my notes. To me, that was still, Ken, one of the saddest stories I've ever heard. You know, and we got to find a way that we get reimbursed for that time. That is our clinical, I mean, really, to me, that's our clinical time. You know, if we're spending that kind of time with our patients, we need to be paid for that. So that is one of my big goals. You know, I'm thinking maybe I should partner with Elon Musk and we could come up with this thing that therapists wear on their shoulders, and it has all the protocols that are appropriate for all the different kinds of patients. And when you're doing the right protocols, it zing, zing, zings a minute and records everything you're doing. And we never have to write another note again. What do you think?
Hey, I think that's great. I've tweeted Elon Musk. He has not responded so far, but I've tweeted him a few times some ideas of how we can add technology and, voice. Yeah, I did. Voice recognition. You know, I tweeted him some ideas and said, you know, you're a visionary, and I think, you know, if you could take some of, you know, just the smallest amount of your resources, we can make a great impact in healthcare. And I talked, you know, part of it is voice dictation. We know it's been around forever. These EMRs that were meant to be helpful actually have made work more burdensome for many.
Yeah.
So, you know, I remember paper notes. We could do paper notes in much less time than these EMRs, you know.
Oh, I agree. But I think we need something that we don't even have to take any time. It records.
Oh, yeah, like a Siri. You just go into the house, and as you're working, it just captures what you've done. It captures every verbal cue, everything that you've done. It just captures it and then filters it into what needs to be documented for reimbursement.
Totally. Because think about it. You know, when I talk to people, they love their trainers. So I had it for, I don't know, maybe a month. And, you know, she'd come over to the house, and I said, well, tell me, do you sit around and think what you're going to do with me today? Do you take notes? Do you know what we... Absolutely not. You know, they don't. They just come in, they do their stuff, they walk out, you get a full hour, you love them. Your therapist, on the other hand, is working with you thinking, oh my God, I got to document this and I got to write down this and I have to be sure and so of course we're not going to come across as involved because we have this other pressure of these notes on our head. Sorry.
Yeah, I tell our clinicians that when we go through orientation and we have new people on board and we're teaching them how to use the laptop, you know, I always tell them they need to think about how they frame the visits with the patients and, you know, let the patient know that, you know, it's not their choice that they're on that laptop for half the time in the home or a quarter of the time in the home, but it's a necessary evil so that the care that they're providing is reimbursed and that they're able to communicate with the other colleagues. You know, if you tell the patient up front what the expectations are, you know, I don't really want to be on this computer. However, I need to be on the computer. Patients are much more accepting of it. If you just go to the home and you're on the computer and you don't explain what's going on, all they see is it was a lot of wasted time from their point of view. Right.
Yeah, but it still makes me crazy that we're doing
it.
We got to fix that. But I can't believe you came with Elon Musk. You're so funny.
Yeah, I tweeted him a few times. If anyone follows me on Twitter, they'll see that I tweeted him. Let's talk. We need to talk. You know, have some ideas I'd like to share with you. So far, he hasn't taken me up on it. Probably never will. But I'm trying.
Ken, if you just keep annoying the crap out of him, and once he gets to the point where it's like, okay, this guy's, I just gotta answer this guy to let him stop.
Let me get I love it.
Yeah, I mean, for real. And you know, Ken, kind of switching to your perspective on this issue a little bit more, and you know, for that newer clinician working in the home health setting, what are some of the best tips that you would give them, besides what you've kind of already mentioned, for them to be kind of the most successful and to avoid burning out in those settings?
You know, I liked what Carole had said about being in a negative work environment and how to look at things and reflection. But to add on to that, you know, when I applied to PT school, I was accepted to PT school. You know, I felt very proud. I think we are a proud profession, and I think we have a lot of clinicians that do excellent work. And we know there's a lot of history behind our profession. And, you know, when you mention, people say, well, what do you do for a living? I'm a therapist. Like, it gets a response from most people, a very positive response. So, you know, we start off in PT school very positive. We graduate, everything's very positive. And then what happens is we get into the P word. And really that P word is productivity. And I think the productivity bogs us down. depending on where we work, our caseloads are very large and hard to manage. And so I think that, and then the documentation behind all the patients that we're seeing, I think those are really two big areas of burnout. I go home and I do a lot of charting. I don't have time for me. I'm seeing a lot of patients running around, not really feeling I have the time with each patient individually. And so I think the way to turn that around really has to be with looking at where we're working. You know, if we're working in an environment that doesn't fulfill us, then that's something that we need to maybe change that environment. And if we can't change the environment, then we need to move on to another practice, another either setting or another environment. I think that the most important thing outside of looking at our profession specifically is really looking at our work-life balance. You know, there's been a lot of research probably about 15, 20 years ago where that became in vogue is, you know, what's our balance of work to life? And do we actually make schedules and have time for our family and make it intentional, have playtime? And I think a lot of people don't have playtime for whatever reason, sometimes intentional and sometimes it may be demands of their job. But I think that's something that people need to be in tune with. You know, when you're working, if you don't have me time, then you need to reevaluate how you can develop some me time. And it doesn't have to be a lot of time, but there needs to be some type of time each day to reflect and each day to wind down. And if every day is just, you know, morning to night, paperwork, patient visits, I think that is a real way to get burnout much more quickly.
Yeah, those are some great tips, you guys, and I appreciate your take on that. What are some of the best resources for professional development and continuing education for the practitioner who's working in the acute care, ICU, skilled nursing facility, and home health settings?
That could be the best question I've ever been asked. Considering I own continuing ed companies, thank you for the opportunity to respond to this. I wouldn't have done these companies if I didn't think that what was out there wasn't hitting the mark, and it isn't. I really think there's a lot of con ed, and there's some good con ed. There's a lot of continuing ed that doesn't address what the clinician wants. You know, going to a course that talks about all the background information and all the theory, and doesn't really give you a lot of evidence-based things to do is not a good course for people. So I, many years ago, started lecturing, and my very first lecture was in Flint, Michigan, with 5 slides, 6 people, and I went on the circuit, and the last lecture was 150 people in New York City on geriatrics, first course ever presented. And it was amazing how many people were interested in the 80s in geriatrics. So I started realizing that people were interested, but there's just not a lot of information out there. And so I think you got to find courses. I mean, nothing makes me crazier than to see a slide that says, doesn't give a rep favorite. I'm joking. Or to see a slide that says Smith, 2000. I like to go to the original research to see if what they're saying really is what that, I mean, I can't tell you how many letters I've written to the editor for the New England Journal of Medicine and Physical Medicine and Rehab that really look at, I mean, some of these, there's a headline study that came out in Journal of Bone and Joint Surgery that said physical therapy is not needed for total hip replacement. That's the title. If you look at the study, oh my, what they did is they had groups, and if people needed more therapy, they were able to cross over. Or if people weren't doing well, they were able to cross over to the physical therapy group. So how can you put a big title that says people don't need physical therapy for total hips? What that title should say is people who do really well with a home program don't need physical therapy. But all these other people crossed over. So, you know, there are people that definitely need physical therapy. There might be a small carve-out that doesn't need it, but don't publish an article like that. So my thought is you need people who really go in, and I know Ken does this, he teaches with me. They go in, they look at the literature, they dissect it, and then they put it in a form where the clinician can really appreciate what the literature has to say about what they do. I love it, you know, because what I do, for example, I have a lady who has knee OA I'm going to see today, and she said, I just can't go down the stairs. So I pull together all the information that I have so that I'm ready with all kinds of ways of treating her depending on what symptoms I see based on the literature. I mean, I think that's the way that we can be great clinicians. But it's hard to get that literature. There's so much stuff out there. And what I like about great seminars in books and great seminars online is that we give you all those references about what we're talking about. We make them very easy for you to access so that if you want more information, you can get it. And I think, courses that do that, and I'm not saying only Great Seminars does this. I've been to other courses, where you sit and you go, whoa, and you get lots of good information, but make sure that it's good information. I just got a flyer from a course that I saw 2 years ago where I had to walk out. It was so deplorable. This guy said, geriatric patients should never exercise. I lost my mind. And he tried to support it. And he's still lecturing on this. He said, all you got to do is therapy. Really? We're so past that. So I think, therapists have to be questioning. Don't just sit there and, take in all this information. Question. And if you have somebody that can't answer your questions or act like they know it all, question them again. But get good information. And I think, you can get it online. You can get it at live courses. It's whatever works for you. How do you learn the best? Okay. Thanks.
Yeah, I want to add to what Carole said. I had taken a number of courses actually through great seminars before starting my own, pursuing my own course. And I have to say that the time that I had my courses, and I took Carole's courses, I also took courses from Janine on balance, I took a course from Nicole on cancer. And so I've taken a number of the courses, and I have to say that what I found most valuable and beneficial to me was the fact that the information was immediately applicable on Monday when I took the course on a Saturday and Sunday. And to me, to be able to translate the theory and the knowledge and the research that was shared with me immediately into clinical practice, to me was the most invaluable. And I can't say it enough as to how on Monday I was able to take techniques that I learned over the weekend and apply them, and then have interventions right away with strategies of how to help that patient. And that, to me, that was the most important thing. I didn't have to figure out what my takeaways are from the course. I didn't have to get, agita over looking over a 200-page manual, and believe me, the manuals are quite comprehensive. I didn't have to go searching and finding what would work. It was laid, the courses that I've taken are laid out in a way that, you want to learn about balance? This course has a lot of information on balance. Janine does a great job of how to frame it so that you can utilize it right away. And same thing with Carole and with Nicole. The courses were just wonderful. One of the first lectures that I had given at a CSM, I talked about osteoporosis. And so I had done a lot of research on osteoporosis prior to this session. I said, this is my first session. I wanted to make sure that I had, appropriate new references, less than 5 years, and everything was evidence-based. And so in my research, I found some tools in New England Journal of Medicine and JAMA, some of the more of the medical-ish journals, on how to screen for osteoporosis with the physical exam. And so in 2000, I don't know what year it was, 2012 or whatever, I talked about the wall occiput test. I found the iliocostal distance. I talked about recall height. Some of these tests that are now in 2017 are much more commonplace. And I do see that our practice has changed significantly in 5 years. And I think a big part of it is we do have more clinicians graduating with that evidence-based mindset of looking for the research, so that they're challenging the practices they're working to improve practice. And I think that the continuing education as a whole has gotten better overall. But there are some that are really just, it's all opinion, it's based on old references. So I agree with Carole that all your references should be on your slides and in your reference list at the end, and all of your materials needs to be updated. 20-year-old references may not apply, and there's probably newer research that has more fact behind it, because current therapy research, which was a push from the APTA to get more quality random trials and meta-analyses in place, which now we are having those in place, that showed that we've looked at a cohort of 2,000 people instead of a case report. Well, if I'm using information from a case report on one person, that's not applicable to the population. But looking at a meta-analysis where they looked at 10 randomized trials of 200,000 people to see that these interventions made differences, I think that holds a lot more evidence and a lot more weight. And I think that clinicians that go to the great seminar courses, and I know this sounds like a solicitation is not intending it to be. And there are other great online modules and other courses as well. If anyone needs to speak, we can certainly talk offline. But great seminars provide the most evidence-based research. And honestly, the clinicians are very engaging. And, for the time that you have, which is a considerable amount of time, it feels like the time flies by. Right, Carole? It just passes quickly.
It does.
Yeah, for sure. And I think those are some really good points, guys. And I think that's really good stuff to hear. And, even in general, what you guys have talked about today, I think we had a lot of good discussion on some of the big key issues within this. And thank you both for the great insights to this realm of PT, as, I've certainly learned a bit. And, we like to ask this last question to each of our guests at the end of every episode, because we're always curious to hear what everyone thinks. And the question is, if you could change one aspect of healthcare education, to DPT or other healthcare provider related, which aspect would you change, and how would you change it?
I would start teaching therapists about how to get out into the community, to work in that preventive realm. And everybody says, oh, yeah, we got to do a visit, and yeah, we have to get out in the community, but nobody knows how to do it. I say to my classes, what tool would you use? I mean, if somebody came in, walked into your office and said, I want to see if I'm going to age healthy, what would you do? What would you pull out? So I talked about this in my McMillan, and I realized there really wasn't any great tools out there. There's some. Most people don't know them. So I came up with the Moving Target Screen. And if you go to movingtargetscreen.com, it's available for free. You can download it. And it just goes through the areas I think we're really the leaders in. Posture, flexibility, strength, balance, endurance, and we just, get through some really good tests like Ken talked about, wall occiput distance. If you flunk this, you're at risk for fractures. So, getting people at age 50 to work on their posture so that at age 70 they're at the point where they can't lift their head up anymore. They have campicormia. So I think we really have to stress. And when I hear what people are teaching in prevention, they're talking about, we can add to what people who have diabetes. Yes, we can. But are we going to actually go in and physically treat the diabetes? No. Are we going to give them a good endurance program to work on that, or maybe a proprioceptive program where we're going to see where they have strength weaknesses? Yes. So, a lot of these forms that people have are just long and peripheral. I think we can make a huge impact, but people have to have a focus to be able to do prevention. They need to, say, this is our area. Nobody in medicine knows exercise and the components of it better than we do. And, when I'm with my fellows, I don't teach in the PT school, I teach in the medical school. When I'm with my fellows, they come to me for advice on all these areas because I'm the expert. We're all the expert in it. But we have to be able to put it out there for the community.
Carole, what you just said actually is one of the points I wanted to bring up, and I'm so happy that you brought up the moving target screen and prevention. For anybody that is not aware, APTA has a new council on prevention and health promotion. I think that this is an area where if I had to go back to what I would change about our educational system and therapy, I'm talking specifically, I think that therapists need to be trained in the fact that they're involved in prevention as well as secondary prevention of health impairment. There's tremendous amounts of research about physical activity and diet and lifestyle choice with aging and with chronic disease. And so, I remember a few years ago, I was told by, and I can't recall who it is, but I was told that, therapists don't treat diabetes. And, back then, in my olden days, I really didn't have an answer. But now I have an answer, and, there's plenty of articles that say physical activity at the appropriate amount of activity, 150 minutes per week at moderate intensity reduces the risk of diabetes, type 2, cardiovascular disease, and stroke. And now we have specifics regarding, and they need to laboratory research that for insulin resistance and how physical activity actually improves insulin sensitivity, reduces insulin resistance. And so we can actually, if we have patients lose weight and with our exercise prescription, can actually prevent getting diabetes. And that was a New England Journal of Medicine article in 2002. So, it's not new information, and I think therapists need to come on board, and I think CAPT needs to come on board and add prevention and secondary prevention into our training. and also the fact that we need to be engaging as clinicians, we need to be trained to engage CMS and engage the payers, and need to be able to relate to things like ROI, return on investment, cost-benefit analysis. I think there's things that therapists need to learn in PT school related to business acumen that we were not trained typically, and so we weren't able to speak the language. I think we're moving in that direction, but I think that's something, if I had my way of looking back, of things that I wish I would have had in my training.
Yeah, those are both some really great points, you guys, and I can't thank you enough for coming on the show today. I mean, we've gained a lot of insight, and I'm sure our listeners will as well. Where can our audience find you guys online and on social media?
So the easiest way to find me is if you follow me on Twitter, it's the @KenMPT, @KenMPT is my handle for Twitter. And if you go through that, you can instant message me if you want to talk individually offline. If you Google my name, you can also find me through I work through Toro College. You can find my email address through Toro College. So those are the two easiest ways to reach me.
My Facebook account, I got Facebook and I got Twitter. So Facebook is Great Seminars for Physical and Occupational Therapy, and Facebook is Great Seminars and Books for Physical Therapy, and our Twitter account is @GreatSeminars. You can get me on any of those.
Awesome, guys. And thank you guys so much for coming on again. And, to kind of add to what you guys said about the prevention, I do want to give a shout-out briefly to Mike Eisenhardt and the Academy of Prevention and Health Promotion Therapies at the aphbt.org. They're doing some really good work with, really working to work on the preventative side, to really work on getting therapists working in that realm. So I just wanted to give a shout-out to those guys, too, because they're doing some great work. But, thank you both so much for coming on with the insight. It's always a pleasure, and I'm really thrilled to bring this information to our audience. So thank you both.
Oh, thank you. It was fun.
Yep. Thank you very much. My pleasure.
Thank you for attending class today, and we hope that you learned something and gained value from the content.
If you'd like to schedule office hours with us, feel free to add us on Twitter @HET Podcast, on Instagram, HET Podcast, on Facebook, the Healthcare Education Transformation Podcast, and the homepage, healthcareeducationtransformationpodcast.com.
And for those of you following along in the syllabus, extra credit can be obtained by liking us, sharing us, and leaving a review.
Let's continue our journey up Mount Educational Success as lifelong learners.